All right, so section M, we're going to cover section M until around 3:15 or so. And then we're going to take a break, and then we'll come back and finish up whatever's left for section M. Again, I just want to make sure that people have materials ready to go. Please keep out your IRF-PI. Please keep out your case study, because we're going to use that. And then if you hadn't already taken out of your packet or pulled down from the web, the Section M coding scenario practice coding sheets, so that you have those to practice as we go through Section M. So if you take those out, that would be great, and just have them available. All right, so we're going to talk about Section M, skin conditions. And so hopefully we'll have a working knowledge. We're going to articulate the intent for Section M. We're going to understand the updates to the IRF-PI related to Section M and be able to interpret the coding options. And then ultimately, we hopefully are going to accurately code Section M. So Section M, new items. It's M0800, worsening and pressure ulcers since admission. And this is assessed on the discharge assessment. Some of the existing items that you're already doing, M0200, unhealed pressure ulcers. Those are assessed, again, on admission and discharge. M0300, current number of unhealed pressure ulcers, again, at admission and discharge. And M0900, healed pressure ulcers, which is done on discharge. So the intent is to document the presence or appearance and change in a pressure ulcer. And as we know, that's a localized injury to the skin or underlying tissue, usually over bony prominence as a result of pressure or pressure in combination with shear and friction. Probably the biggest issue for some staff is to understand what's pressure, what's fungal, what's some of the other things that they're looking at. So I think that's where the greatest opportunity is in educating people so they know exactly what they're looking at. Staging definitions are adapted from the 2007 National Pressure Ulcer Advisory Panel staging definitions, and I know this came up as a frequently asked question and was a point of discussion at the last IRF training. Why are we using 2007 National Pressure Ulcer Advisory staging definitions when they are much more current? And the answer to that is that this is not used just, so when with the IMPACT Act, we're being asked to align certain assessments across a variety of settings, the long-term care hospitals, the inpatient rehab facilities, the skilled nursing, and home health. And so this is the first opportunity to kind of level set the questions. And so the Pressure Ulcer Advisory 2007 standards and definitions were the ones that have been adapted and used in other settings. So for now, it's what we have. We do acknowledge that there are other more current standards. That does not preclude you from using those standards and documenting in your clinical record using those standards. But for these assessments, you have to use these guidelines. So. Let's see, and then to help identify and evaluate risk and determine the etiology of all skin ulcers, wounds, and lesions, and to ensure appropriate treatment. So every time that there's an update with the National Pressure Ulcer Advisory Panel, or as the science of pressure ulcers or pressure injuries, and as the verbiage change, it's a rapidly changing environment. And so when you think about anything that we do related to assessments, payments, quality reporting, it doesn't happen overnight. It takes time. And it takes, especially now, this is a huge endeavor to start this whole aligning process across the post-acute environment. I can tell you, as being an expert in geriatrics and in long-term care, and we've been using these assessment tools for so long, and also being on many, many contracts and sitting with CMS and realizing you can't just, you're like, why can't you just do this or just tweak it or just change it? There's no just tweaking. There's no just changing. There's this huge, you think about tossing a pebble into a pond, there's this huge ripple effect that sometimes when you're sitting as a clinician in the environment, you don't realize the impact of that. So I say that from a person who asked that question, why can't you just? And then I've learned that there is this huge ripple effect. And, over time, the goal is, I think, to bring things to current standards, current evidence, and make it the same over all of the settings. But, so we do have work to do on that. And so, anyway, we will move on. So M0200-210, we have unhealed pressure ulcers. I'm not going to spend a whole lot of time because you've done this. IRFs must code IRF-PI according to the manual instructions, and this is where it's going to be hard for your clinical staff when they may be documenting clinically one way and then have to change a little bit. So using the MPU definitions in your manual. Code the admission IRF-PI assessment in terms of what is assessed as close to the admission as possible. Now that's another frequently asked question. Well, we have 3 days to assess. What if it's this? We do the initial skin assessment within the first couple of hours of admission, and then 3 days later we see something else. The idea here is to try to get what is the condition of the skin as close to the point in time in which they come into your environment. All right, so even though there's a 3-day assessment time, it's really, especially with skin, this is one where we really want to know what is their skin like when they come into your environment. Let's see, so numerically stage the pressure ulcers, determine if it's unstageable, look at and determine it also if it's a suspected deep tissue injury. We want to use things like description and classification of anatomical depth and soft tissue damage, visible or palpable tissue damage in the ulcer bed. So if it's covered with a little slough or eschar, but we can see down and we see bone and tendon, then we know that we can code that. And this helps inform the expectation of potential healing times. So how are we going to get this information? Well, we're going to review the medical record, including skincare flow sheets, other tracking forms, speak with direct care staff, and the treatment nurse or wound care specialist, whoever manages your wounds. Confirm your conclusions, clarify, ask questions from the medical record. Make sure that you are comfortable with what's documented, and then you can code the IRF-PI. We want to conduct a full body assessment of the patient to determine whether any skin ulcers are present. You want to do this again as quickly or as close to admission as you can. Make sure you assess high risk areas for pressure ulcer development, especially if they're using oxygen or have other kinds of tubes and whatnot. So ears are a big area, behind the ears. If they have some sort of a tube, let's say a feeding or whatever, if it's into the nose, just make sure that we're looking at all the high-risk areas. Make sure you examine the patient in a well-lit room, especially if they're a person with darker skin tones. It's much harder to pick up, especially maybe a suspected deep tissue injury or stage 1 pressure ulcer. So make sure you have really great lighting. We want to make sure if we identify any pressure ulcers that we're going to record the deepest anatomical stage, and identify any known or likely unstageable pressure ulcers. So we want to make sure we record all of this. So for this question, M0200, we're asked, does the patient have one or more unhealed pressure ulcers at stage 1 or higher? So that's the first question. They either have it or they don't. So we code no if the patient doesn't have a pressure ulcer in the 3-day assessment period, or 1, yes, the patient has a pressure ulcer. So let's see. Make sure the primary cause of the ulcer is pressure. Then it should be included as a pressure ulcer. Remember, if we want to call it a pressure ulcer, you have to be able to relieve pressure as part of the treatment plan for that. So this, again, is really important to make sure your staff understand, are we dealing with a diabetic ulcer? Is this a peripheral vascular ulcer? Is this an arterial ulcer? Or is this a pressure-related ulcer? So skin is not as easy as we think it is. So we want to make sure that whoever's assessing this and determining it knows exactly what we're looking at. Terminal illness or end-of-life ulcers, also known as Kennedy ulcers, should be assessed and staged, but not coded as a pressure ulcer on the IRF-PAI. So if you have a documented Kennedy ulcer in your medical record as determined by your practitioner, you can certainly do everything else clinically you need to do for that ulcer, but you're not going to code it on the IRF-PAI. Mucosal ulcers, those related to nasogastric, tubes, oxygen tubing, endotracheal, whatever, should not be coded on the IRF-PAI. So we're not looking, because it's a whole different assessment process. So mucosal ulcers are not coded on the IRF-PAI. So now we have Kennedy ulcers not coded, and we have mucosal ulcers that are not coded on the IRF-PAI. So that's a good opportunity for training and education with your staff. Also, do not code surgically closed pressure ulcers. So if someone went in and had a flap done or a graft, whether it's healed excuse me, or unhealed, we do not code that as a pressure ulcer. So they could have gone in, had a graft done, and then due to complexity of the patient's condition or whatever, they maybe had a failure in the graft or the flap, and now it's open again. It's still considered a surgical wound, not a pressure ulcer, once that graft has been put in place. And so we would be coding that as a surgical wound. For discharge assessments, if the pressure ulcer is healed and not present on admission, code 0 on the discharge assessment. And we're going to go through all of these. For the discharge assessments, for a discharge assessment, if the pressure ulcer healed and it was present upon admission, complete M0900 healed pressure ulcers. So we want to be able to track that information. If 2 or more pressure ulcers on the admission assessment have merged together and now they're a single pressure ulcer, by discharge, the resulting pressure ulcer is reported as one single pressure ulcer at the appropriate stage on the IRF-PAI. So you have 2 that are, and they call it usually a bridge, a piece of skin between them. Now that bridge breaks down, now they're considered one ulcer. You want to code that as 1 instead of 2. Consider the primary etiology of the ulcer with diabetes. So was ulcer caused by pressure or other factors? So we give an example. If a patient with diabetes has a heel ulcer from pressure and the ulcer is present during the initial skin assessment, that takes place following admission on the IRF code as 1. If the patient with diabetes has an ulcer on the plantar or bottom surface of the foot closer to the metatarsals and the ulcer is present in a 3-day assessment period, code 0. And why would that be? That's where it's important to understand what's a diabetic ulcer versus what is a pressure-related ulcer. So an area that I think, again, clinicians struggle with. If you go out to the kind of the average nurse, unless they've been specially educated in wound and skin, they sometimes can't pick up those subtleties. So it may be important for you to say, how competent, how comfortable am I with my staff accurately assessing what's pressure, and then 2, being able to code it. M0300, the current number of unhealed pressure ulcers at each stage. So we wanted to determine what's the deepest anatomical stage, identify if it's an unstageable pressure ulcer, and we're going to go through a couple of the different types of unstageable pressure ulcers, and determining if it's present upon admission. And there's detailed instructions in the manual related to this. So here we have, so a patient is admitted to the facility without a pressure ulcer. During the stay, she developed a stage 2 pressure ulcer, and this is a facility-acquired pressure ulcer and was not present upon admission. Okay, so here we have admitted to the IRF without a pressure ulcer, develops a pressure ulcer in the IRF facility, transferred to the hospital for an acute change in condition, returns to the IRF after 2 days with the same pressure ulcer that was facility acquired. So when we're coding this, the pressure ulcer is not present upon admission. Does everyone get that? Because it wasn't present upon admission, okay, because they're admitted without it. They develop it. They go out to the acute care. They come back with that same ulcer, same stage and everything. So it wouldn't be coded as present upon admission. Everyone have that? Looking around, I got people kind of questioning that. All right, let's look at another example. Patient admitted to the IRF with a pressure ulcer, so not facility acquired. So they come into your facility with a pressure ulcer. They're transferred to the hospital or acute change in condition. They return to the IRF after 1 day with the same pressure ulcer that was not facility acquired. Then we would code that still as present upon admission, because they had it when they came in, they were transferred out, they came back with that same ulcer, we're considering it present upon admission, because it was acquired outside of your organization. So then we're going to go into the staging. I don't think we need to spend a whole lot of time on this. Stage 1 pressure ulcer is basically non-blanchable redness. For someone with darker skin tones, it could be a bluish tone to it, and it's non-blanchable, usually over bony prominence. The pressure ulcer, an observed pressure ulcer, alteration in tactus skin. And so you may see an alteration in the skin temperature, tissue consistency, sensation. It's an area defined really a persistent redness or light pigmented skin, and darker skin tones you may appear as red, bluish, kind of purplish tones to it. Stage 2, we have partial thickness, loss of dermis, presenting as a shallow open ulcer with red pink wound bed. The biggest thing here is without slough. So if your staff member is saying it's a stage 2 upon admission and describing slough in it, what is that telling you? It's not a stage 2. So opportunity to educate, an opportunity to make sure that that practitioner understands that, with the slough, as long as you could still see the bed, the fact is that that probably minimally is at stage 3. And it also may present as an intact or open ruptured blister. So the stage 3 pressure ulcer, this is your full thickness tissue loss. Subcutaneous fat may be visible, but bone, tendon, or muscle are not exposed. Slough may be present, but does not obscure the depth of the tissue loss. So if you had an ulcer and you couldn't see down to the deepest level, of the wound, then it would be an unstageable pressure ulcer. But if you have just a little bit of slough and you could see to the deepest part of this ulcer, you could go ahead and stage it as a stage 3, as long as we do not have bone, tendon, or muscle exposed. And we could have undermining or tunneling included with this. And of course, our stage 4 pressure ulcers. These are your full thickness tissues, full thickness loss, tissue loss with exposed, often bone, tendon, or muscle. Slough and eschar may be present at some parts of the wound bed, but if you can see bone, you got a stage 4. And many of these often include undermining and tunneling within them. So now the unstageables are the ones, again, that people struggle with a little bit. So we have the opportunity to code a couple of different types of unstageables. So M0300E is unstageable pressure ulcer related to non-removable dressing. So it includes, for example, a primary surgical dressing that cannot be removed, or an orthopedic device or cast where you know there's an ulcer underneath it because they told you that, but you can't check it yourself, right? So you can't stage it yourself. You can't get to that ulcer. So you would say it's unstageable due to a non-removable device or dressing. Then we have M0300F, which is probably the most common that we're going to have, is unstageable pressure ulcer related to slough or eschar. And slough is non-viable, yellow, tan, green, gray, brown tissue, stringy, usually moist, can be soft. Not so pleasant. It may be adherent to the base of the wound or present in clumps throughout the wound bed. It's not the type of thing that you can spray a little wound cleanser on or wipe and it goes away. It sticks to the wound. Anyone who's done any kind of wound care for any length of time can tell you exactly what that looks like. eschar, on the other hand, although it's still part of this unstageable, is dead or devitalized tissue, it's usually that is hard or soft in texture. It's usually black, dark brown. It can be tan in color. It may appear like a scab. I think that's probably the best definition of looking at eschar for me. Necrotic tissue and eschar are usually firmly adhered to the base of the wound and often to the sides and the edges of the wound. So it doesn't, again, won't clean off by just wiping it. And then we have unstageable pressure ulcers related to a suspected deep tissue injury. And a suspected deep tissue injury is usually purple or maroon area of discolored intact skin due to damage of underlying soft tissue. The area may be preceded by tissue that is painful, firm, mushy, boggy, warm, coolness. There's something different around the tissue, and then you have this purpley area. And we don't know how the extent of that wound until it declares itself, and then actually we can stage it. So for M0300A1 through G1, complete on admission and discharge assessments. We're going to enter the number of pressure ulcers that are currently present and enter 0 if there's no pressure ulcers present. M300B2 through G2 is completed at the time of discharge. We're going to enter the number of pressure ulcers that were present on admission, and then I give you some instructions of where to find that, and for determining whether it's present upon admission, and then enter 0 if no pressure ulcers were noted at the time of admission. And we're going to go through some of the examples here. So we have a coding scenario, and so on admission, the patient has 3 small stage 2 pressure ulcers on her coccyx. And actually, if you take out your Section M coding scenarios practice coding sheet, and for those in streaming video, if you pull this out, work this along with me, and let's code this as we go through this scenario. All right, so on admission, the patient has 3 small stage 2 pressure ulcers on her coccyx. 3 weeks later, upon discharge, the coccyx is assessed. 2 of the stage 2 pressure ulcers have merged, so now it's 1 ulcer. And the 3rd ulcer has increased in numerical stage to a stage 3 pressure ulcer. I'm going to give you a minute. So I want you to complete that scenario. All right, we ready? Hopefully you're ready there on streaming video that you've coded this. All right, so how would you code M0300B1, the admission assessment? The number of stage 2 pressure ulcers on admission. How many did they have on admission? 3, correct. Number 3, stage 2 pressure ulcers on the coccyx. Okay, so then how would you code M0300B1 for discharge? Number of stage 2 pressure ulcers on discharge. 1. And why do we have 1? Because we had 2 of the stage 2s merged together and became 1, correct? And the 3rd one became a stage 3, okay. Number of these stage 2 pressure ulcers present upon admission. And then it is in the discharge assessment, the number of these stage 2 pressure ulcers that were present upon admission. We have 1, right? Okay. So what you're saying is in B1 there, you're saying I have 1 stage 2 pressure ulcer, okay? Of the stage 2 pressure ulcers, were any of them present upon admission? And in fact, yes, right? Because those 2 had merged into 1 and I still have that. Number of stage 3 pressure ulcers on admission? Right? 0? We didn't have any? Is that true? right? Okay, we had 3 stage 2s. Okay. And then number of stage 3 pressure ulcers on discharge. Right. Number of these stage 3 pressure ulcers that were present upon admission. How many of them were present upon admission? Mixed feelings here. What do we have? Anyone? 0? Right. They didn't have, right, because she was admitted. Think about that. How many of them were on admission? She didn't have any, right? She had 3 stage 2s on admission. She didn't have any stage 3s. Okay. And so this is your rationale. It's written out here. 2 of the pressure ulcers on the coccyx have merged, but have remained at the same stage, and they were at the time of admission. So that's coding that as 1 at discharge. And the pressure ulcer that increased in numerical staging to a stage 3 has developed a deeper level. So it wasn't there on admission, but it is there on discharge. Okay. So now let's look at coding scenario 2. And again, if you just flip your page, you have coding scenario 2. You have the opportunity again to complete your assessment. So Mrs. J is admitted with 4 stage 2 pressure ulcers and 1 stage 3 pressure ulcer. Okay, this is on your admission assessment. During Mrs. J's stay, 3 of the stage 2 pressure ulcers healed. However, Mrs. J develops an additional stage 3 pressure ulcer. So this is getting a little more complex. Okay, we ready? All right, so let's go ahead. Number of stage 2 pressure ulcers present upon admission. 4. Okay, great. All right. So number of stage 2 pressure ulcers. Let me just make sure I'm getting to right here. Number of stage 2 pressure ulcers on the discharge assessment. Correct? 1. Number of these stage 2 pressure ulcers present upon admission. Remember, we're referring to the one above. How many of the one above were present upon admission? Right? Okay, you see how that's referring to the question before. Okay, so 1. Number of stage 3 pressure ulcers upon admission. I hear 1. That's correct. We had 1. Okay. Discharge assessment. Okay. How many do we have now at discharge? We have 2. All right. Number of these stage 3 pressure ulcers that were present upon admission. Right. So what story is that telling you? Okay. So they ended up, when you're talking about the discharge assessment for stage 3, you have 2 at discharge. 1 of them was present upon admission, so 1 developed in the organization. Okay, that's the story that these numbers are telling you. And then we go into a detail kind of rationale around the pressure ulcers. So there were 4 stage 2 pressure ulcers present upon admission, but prior to discharge, 3 of the 4 stage 2 pressure ulcers healed. The patient had 1 stage 3 pressure ulcer on admission and then developed 1 more during their stay and did not heal, and they didn't heal prior to admission. So we ended up with 2 at discharge. 1 of them was present upon admission. All right. So now let's go to scenario 3. So just take your coding sheet out and you go to 3, or coding scenario 3. And again, these are great kind of scenarios, and you can do these with your own staff. So you can come up with your own scenarios. You can use our scenarios. It doesn't really matter. But this will help them to kind of work through this thought process. Okay, so Miss P enters the IRF with a pressure ulcer assessed upon admission at a stage 2. On day 3 of the patient's stay, the same pressure ulcer was assessed to be a stage 3. Upon discharge, Mrs. P was noted to still have a stage 3 pressure ulcer. I'm going to give you a second to fill out your form. Okay. All right. So let's start going through the coding here. Number of stage 2 pressure ulcers on admission for this patient. Any guesses? 0. What else? 1. Okay. It's actually 1. So it says Mrs. P enters the IRF with a pressure ulcer assessed upon admission as a stage 2. And we're going to talk this through. Okay. Discharge assessment, number of stage 2 pressure ulcers on discharge. 0, right. Number of these stage 2 pressure ulcers present on admission. We'd skip, right? Why would we skip that? Actually, in the instructions, in the coding instructions on the manual, you'd skip because it's asking you of these, meaning of the question below, before it, how many were present upon admission. You're saying 0. Okay? So you couldn't say, you have to skip. And it says if you have a 0, skip this question. So you would have seen that. And if you have a computerized system, it's going to force you, it's not going to let you answer this question. It will force the skip. So makes your life easier. I love skip patterns built into computers. Okay. Number of stage 3 pressure ulcers upon admission. 0, right? How about on the discharge assessment? Correct. Number of the stage 3 pressure ulcers present upon admission. Right, 0. Okay, so now let's talk this one through because I think there was some little confusion here. So the stage 2 pressure ulcer was present upon admission. I think we agreed that. And even though the wound worsened during the 3-day assessment period, the initial stage of the pressure ulcer is captured because it reflects the patient's skin assessment at the time of admission. And we kind of alluded to that in the beginning, right? Because a lot can happen in 3 days stay. But this is reason it's really important that whoever's assessing the wound understands how to stage. They need to understand what they're looking at and what it is. I think I gave an example at the last time that I did training. You might come into the situation where someone is describing their stage, and I think I said this a little bit earlier, they're saying it's a stage 2 pressure ulcer. They give you the measurements and then describe the wound as having some slough on it. Not completely occluded by slough, but having some slough. It can't be a stage 2 and have slough. And so your staff need to know that. So in that situation, and maybe that was done at 4 hours post-admission, with that nurse describing the slough and describing the yellow, whatever, what that's telling you is that wound was never a stage 2. It was always a stage 3. Or if they had taken a picture, I know there's a lot of people who don't do pictures because of legal issues and whatnot. But in that situation, it's a little different because what they're describing in clear words is something not of what the person has staged. That's an opportunity for educating the nurse. So in that situation, it wouldn't have been worsened because what they described at a couple of hours at that initial skin assessment really was a stage 3. So just take the opportunity in those situations to really educate. It's going to be important to do that. Does everyone get the kind of the sense in this scenario? We made it a little bit more complex for you? All right, because that actually came up as a frequently asked question. All right, so we're going to spend a little bit of time about worsening pressure ulcers since admission, and it's actually, and someone had suggested this, why don't we relabel this question because it's really new or worsening pressure ulcers. I agree. I'd like it to be named differently, but that's the intent of this particular section. And so we are looking at stage 2, 3, 4, and then all the unstageables. And the rationale is to document whether the skin assessment overall has worsened since the admission assessment, the number of new pressure ulcers, and whether any pressure ulcers have increased in numerical stages. And this, you'll see, the number of new pressure ulcers is what's not in the title of this particular section, but that is part of the intent and the rationale. So it's new and or worsening. So pressure ulcer tracking certainly is consistent with good clinical care. It's reevaluation of the interdisciplinary care plan to ensure adherence to appropriate preventative measures, to make sure that we're using the appropriate treatments and pressure relieving devices and whatnot. When we get new pressure ulcers or if they get worsened, so we want to adjust our whole treatment plan. So this is an important item for us to look at. So pressure ulcers that progress to deeper level of tissue damage is one that we want to capture on worsening. Stage at a higher number using the numerical scale of 1 through 4, increasing in severity to reflect the progression. Remember, we don't reverse stage, right? Reverse code. For any of you who worked in SNFs years ago, we had this horrible thing when we forced people to reverse stage. So if an ulcer is a stage 4, it's always a stage 4. It may appear less than that, but it is a stage 4 if that's what it was staged at. We look at the discharge assessment as compared to the admission assessment, and absence of a pressure ulcer, skin breakdown, or damage is scored as a 0, and that's always nice if we don't have those. So code or complete at the time of discharge based on the pressure ulcer coding at the time of admission. So we want to review the history of each current stage 2 to 4 or unstageable pressure ulcer. This is really where it's going to be important to look at not only your assessment in your organization, but if they came into your organization with an ulcer, they might have either had an ulcer at home and then ended up in the acute care setting and then ended up in the IRF. They could have been in another setting, then into the acute care, and then came to you. So it'd be important to try to glean from discharge records or transfer records what that wound was assessed at. For each current stage 2 through 4 and unstageable pressure ulcers, determine those that were not present or have worsened since admission. So review the history of each one of these and compare the number and status of pressure ulcers as documented on the admission assessment with the number and status of current pressure ulcers at discharge. So you start to see where these all build upon each other. So it's really important that whatever we assess on admission is accurate and clear, and we know that it is relevant for that particular patient, because then we're going to be coding it on discharge. Great opportunity for educating. So we are going to be coding the 2 through 4 unstageables, not present, or are new, or were on a lesser stage on the admission as compared to on the admission assessment, and compared to the number and present on the discharge assessment. And again, if there's none, we're going to code as 0. Coding as worsened. The pressure ulcer that increases in numeric stage from admission to discharge is considered worsening. If a stage 1 or 2 pressure ulcer further deteriorates and becomes unstageable due to slough or eschar. So this bullet 2 is an important bullet. Why? A stage 1 pressure ulcer and a stage 2 pressure ulcer, if accurately assessed, cannot have slough in them, right? So we know the fact that they develop slough, even if it completely covers the wound, this is the one time we know it got worse, because now it's minimally a stage 3. So this is an important bullet. Because in other statements, you're going to see when a wound, let's say a stage 3, and we're going to give this example, it comes around, but if you have a stage 3 and then it becomes completely covered with slough, so now it's unstageable, it doesn't necessarily mean it's worsened. And so people get a little confused by that second bullet. They'll say, but Ann, you just said if it gets covered with slough, it's worsened. And I'm saying no, only in this particular situation is it considered worsened. And that's because a stage 1 or 2 cannot have slough in it. And so I think we kind of cover this. If a previously numerically staged pressure ulcer becomes unstageable and is debrided sufficiently to be numerically restaged by discharge and the pressure ulcer stage is increased, then we're going to say it's worsened. But if in fact you had a stage 3, then it became covered with slough, then you chemically debrided it, and after it was cleaned and the slough was removed, it still was a stage 3. Is it worsened? No. Still stage 3. So do not code as worsened if something was already staged as a 3 or 4 and then becomes unstageable due to slough or eschar. Just because it's covered in slough and eschar with an already known 3 or 4 does not make it worsened. All right? Because we don't know what it's going to be when it gets uncovered. So just because it has slough does not mean it's worsened. If a pressure ulcer is unstageable on admission and is able to be numerically staged only at discharge, code the appropriate stage at M0300. If this is the first time the pressure ulcer was able to be numerically staged. So if they come in with an ulcer, it's fully covered with slough, it takes whatever time that we're there to clean it up, and now on discharge, we now know it's a stage 3 because it's clean. It's we can't say it's worsened, right? Because we didn't know what stage it was when they came in. Now we're just going to actually stage it. If 2 pressure ulcers merge to increase surface area, but the numerical staging has not increased, we don't consider that worsened, and I think you guys have that pretty well set. We already covered that. Okay, so if you have a numerically staged pressure ulcer present upon admission, becomes unstageable during the stay, is debrided, and after debridement is able to be restaged numerically, and the reassessed stage is higher than the previously numeric stage, the pressure ulcer is considered to have worsened. So if they came in with a stage 3, it became, if they came in and it was unstageable, then you cleaned it, you were able to stage it as a stage 3, and then it was reassessed at a higher level, maybe a stage 4, then we would say it was considered worsened and no longer present upon admission. If a numerically staged pressure ulcer with present upon admission becomes unstageable, cannot be numerically staged, is debrided, and after debridement is able to be restaged, and the reassessed stage is the same as previously, it is not considered not worsened, and I think we already talked about that. So in the there's all these what ifs. If an unstageable pressure ulcer that was present upon admission is debrided and is subsequently able to be numerically staged, the pressure ulcer is to be considered not worsened and present upon admission because this would be the first time the pressure ulcer was able to be numerically staged. So that's the person who comes in with slough or eschar covering a wound, you can't stage it, and then now we stage it. The first time that we can stage it, we do, and we also count it as present upon admission because it was there when they came in your doors. If subsequent to the numerical staging, the pressure ulcer further deteriorates, then it's restaged at the higher numerical stage, and now the pressure ulcer will be considered worsened and not present upon admission. And hopefully that makes sense. These are real fine points, but they're important points. So you kind of have to look at these and say, you know, if it's the first time that I can stage it, we're not going to consider it worsened. And if they had that unstageable wound when they came in, great, now we stage it as a stage 3, we consider it present upon admission. But now if that stage 3 that now we consider present upon admission deteriorates now to a stage 4, we now reclassify it as a stage 4 and we say now it's not present upon admission because it got worse. Okay. So here, just basically something we've already talked about. So stage 3 pressure ulcer, while the patient develops it while they're at the IRF, then it's subsequently covered with slough. It now becomes unstageable. By the time of discharge, the patient record notes that the debridement was performed, and we still have a stage 3 pressure ulcer. After debridement, the wound bed is reassessed numerically at a stage 3. So in that particular scenario, what we have here is number of stage 3 pressure ulcers upon admission. So in that scenario, just to remind you, the patient developed a stage 3 pressure ulcer while at the IRF. So number of stage 3 pressure ulcers at admission. Any thoughts? 0, right. Okay. So it didn't have any pressure ulcers, stage 3. At discharge, how many stage 3 pressure ulcers? 1. Okay. Number of these stage 3 pressure ulcers upon admission? 0, right? Okay. He came in with no stage 3s. On discharge, he has a stage 3. And then we're saying the number of stage 3 pressure ulcers that were present upon admission, we say is 0. The next question is worsening of pressure ulcer status since admission, stage 2. Do we have any new or worsening since admission for stage 2? No, so we're coding 3. We're coding 0. Worsening of pressure ulcer status since admission, stage 3. So new or worsening? Remember the word new? What do you think? Everyone's tired. Okay. Stage 1. Coding as 1. I'm tired. So we're coding as a 1 because he has a new stage 3 since admission. He didn't have it stage 3 on admission, so it's new. How about for stage 4? Right, we didn't have any stage 4s. Okay, worsening pressure ulcer since admission, unstageable, non-removable dressing. We didn't have any of those. How about pressure ulcers new or worsening that were unstageable due to slough or eschar? Do we have any of those? No? Okay, I've got a lot of people nodding no. How about worsening of pressure ulcer since admission, unstageable due to deep tissue injuries? Do we have any of those? No. Okay. And so on the discharge assessment, M0300C1 is coded as 1, and M0300C2 is coded as 0 because the stage 3 pressure ulcer developed in the IRF and was therefore not present upon admission. M0800B is coded as 1 on the discharge assessment because the stage 3 pressure ulcer is noted on the discharge. Even though it is not considered worsening after the ulcer was reassessed after debridement, the ulcer developed in the IRF and therefore is coded as a new pressure ulcer that was not present upon admission. And I think we went through all of those coding scenarios with you. I am getting the sign that we are time for break. I think we all could use it. So we're going to take a break for 15 minutes, and then we'll come back. And we will probably not need all the time when we get back, so hopefully we'll get out of here early. It's been a very long day for everyone. So take a quick 15-minute break, get some caffeine, do some jumping jacks, deep breaths, stretching, and we'll see you back in about 15 minutes. Okay, so we're going to push on so that we can get out on time. Just a couple of announcements. Once I finish section M, we will do an open kind of question for open questions for section M. But I did want to let you know that right after we're done with the section M open mic kind of questions, that Ann Deutsch and Chris Gross are going to come up with some of the questions that have already been put in and answer them. So that is good. So don't run away. Hopefully you'll bear with me and we will get through the rest of section M here today. So We just finished up coding scenario 1, and we're going to go into coding scenario 2, and I forgot to tell folks, hopefully you've been following along. You have a coding sheet, oops, sorry, part of the whole packet that you've had here. So you have a sheet for coding scenario 2, and the nice thing is people who are smarter than me and thinking and putting out your handouts, they put the scenario up top so you can follow along for the coding. So now we're going to do coding scenario 2, and a patient was admitted to the IRF from the acute care hospital with 2 stage 2 pressure ulcers, 1 on each of their heels. After 2 days, the left heel stage 2 blister had ruptured and presented as a shallow ulcer with a pink wound bed. The right heel continued to evolve, having a blood-filled blister and matured in color from red to a maroon/purple color, with the area surrounding the blister being boggy, painful, and warm. After discussion with the family and approval by the patient, they decided to care for the patient at home with home care services and asked to be discharged from the IRF against medical advice. So, this is your scenario. And so now we have to go ahead and we have to code the section M0800 for this patient. So I'm going to give you a second. You have your scenario written on the top of the paper under code scenario 2. Same thing for those of you who are doing live streaming. Read your scenario, it's right there. And then I'll give you a second to code this, and then we're going to go through the coding rationale for all of these areas. Okay, by looking around the room, hopefully you on the streaming video have completed. It looks like most people have completed here. So, all right, let's go through the coding. So for M0300B1, number of stage 2 pressure ulcers on the admission assessment. 2, okay, great. Number of, let me just go right to the end here for me. Okay, number of stage 2 pressure ulcers on the discharge assessment. 1, I hear 1. Is that the consensus? Yes, we're coding as a 1. Number of these stage 2 pressure ulcers that were present upon admission. 1, right. So we have 1 on discharge, and of that, 1 was present upon admission. M0800A, worsening in pressure ulcers since admission, stage 2. What do you think? Any new or worsening stage 2 pressure ulcers? Discharge? What do you think? Yes? No? Maybe? So do you agree with the 0? Okay, and we're going to talk through the rationale, but in that situation there, we did not have any new stage 2 pressure ulcers, okay? And we do have 1 pressure ulcer that went from a stage 2 to what? An unstageable, right, okay. All right, so for worsening in pressure ulcer status since admission or new, stage 3? 0, good. Okay, worsening in pressure ulcer since admission, new, stage 4? 0, good. Worsening in pressure ulcer since admission, unstageable due to non-removable dressing? 0. Okay. How about worsening in pressure ulcer status since admission, unstageable, slough, or eschar? Right, 0. And then the last one, worsening in pressure ulcer status since admission or new, unstageable, deep tissue? 1. Right, great job. Okay, you worked through that quite well. All right, so we talked about this on the admission assessment. The M300B1 is coded as 2 because the initial assessment identified those 2 stage 2 pressure ulcers. Then in B1, it's coded as 1, and B2 is coded as 1 because, and F800 800F is coded as 1 on the discharge assessment because one of those ulcers is now being staged as a deep tissue injury, and one of the stage 2 pressure ulcers developed into a suspected deep tissue injury remains that way at discharge. All right, so let's quickly go through a third scenario. So if you turn to scenario 3 on your coding worksheet here, again, it has a scenario on top. A patient is admitted to your IRF with 2 stage 2 pressure ulcers. By the time of discharge, the 2 pressure ulcers have merged and increased in numeric stage to a stage 3. So let's go ahead and quickly assess those. Okay, looks like pretty much everyone is done with the coding. Okay, so number of stage 2 pressure ulcers on admission. 2, okay. Oops. Sorry. Okay. On the discharge assessment. 0, right? Number of these 2 stage 2 pressure ulcers that were present upon admission. It's a skip. Remember we talked about the skip pattern because we didn't have any? Okay, great. Number M0-300C1, number of stage 3 pressure ulcers on the admission assessment. Right, they didn't have any on. How about on discharge? They had 1. Okay. How about any new worsening stage 3s? Zero. Okay. Worsening in pressure ulcer status since admission stage 2. Okay. Worsening pressure ulcers since admission stage 3. Okay. I'm sorry, I'm getting ahead of myself. Worsening in pressure ulcers since admission stage 4. 0. Okay. How about worsening pressure ulcers since admission due to unstageable due to non-removable dressings? 0. And then how about due to slough or eschar? Okay. And then how about unstageable due to suspected deep tissue injury? 0, right. Okay. So let's go quickly through the rationale. So at the time of discharge, the 2 stage 2 pressure ulcers that were present on admission merged, and they increased in numerical staging to a 3 by the discharge. Therefore, M0300B1 is coded as 0, and M0300C1 is coded as 1. And we went through that on the discharge assessment. Since the 2 stage 2 pressure ulcers merged and increased in numerical stage, the ulcer is no longer considered as present upon admission. So the discharge M0300C2 is coded as 0. And then since the 2 stage 2 pressure ulcers merged and worsened to 1 stage 3 pressure ulcer during the IRF stay, M0800B should be coded as 1 on the discharge assessment. So hopefully we have no questions on that. So those are a little, there's lots of questions in this M0800 area, so lots of opportunity for people to understand how to code that. So then we have healed pressure ulcers, which is M0900. So this is one I think that you guys are used to completing. Document the number of pressure ulcers that were present on admission and have healed by discharge. It's completed on the discharge assessment. For each stage, enter the number of pressure ulcers that were present at admission and have completely healed or closed upon discharge, and enter 0 if no admission pressure ulcers were healed on discharge. And we're looking at stage 1, 2, 3s, and 4s. If a suspected deep tissue injury is identified as present on admission, then it opens to an ulcer during the IRF stay and heals prior to discharge. It is documented in M0900, healed pressure ulcer. Discharge as the highest stage it was prior to healing. So let's say that you had a suspected deep tissue injury, it opens, and the ulcer is staged at, let's say, a 3, but then heals prior to discharge. We're going to put M0900 at its highest stage, which was a 3, prior to it healing. So if a patient is admitted to the IRF with 2 stage 2 pressure ulcers, Let's see. One on his left heel and one on his right heel. He is also admitted with a stage 4 pressure ulcer in the sacral area. He develops a new stage 4 pressure ulcer on the right great trochanter area while at the IRF. At the time of discharge, the stage 2 pressure ulcers have healed on both heels, and he continues to have a stage 4 sacral ulcer and a stage 4 pressure ulcer on the right greater trochanter area. So that's our scenario. Now we have to go through and we have to code this. I don't think we have a coding scenario for 9, so let's just do this together. So the number of stage 2 pressure ulcers that this patient had. 2, right? He had 2 of them. Okay. So now we want to know the number of stage 2 pressure ulcers on the discharge assessment. Right? Okay, 0. The number of stage 2 pressure ulcers present upon admission. Be a skip, right? Again, this is a skip pattern because they had 0 ahead of it. Okay, number of stage 3 pressure ulcers present upon admission. Right? On discharge. Right. Okay, number of these stage 3 pressure ulcers that are present upon admission? Skip, right? Okay. Again, when we have 0 above it, it's going to be a skip. And again, if this was in a computer program, this would skip naturally. Number of stage 4 pressure ulcers on the admission assessment? Correct. How about on the discharge? Right. Okay. Number of stage 4 pressure ulcers present upon admission of these? Okay, right. So one of them was present and then they developed another one, right? So of the 2 that we have talked about in stage 4, one of them was present upon at admission. And then, so then we are looking at M0900A, stage 1, stage 2. Okay, we had, so this is looking at the number that have healed, right? So we have 2 stage 2s that healed, remember with the coding, because we've kind of scrunched these all together. How about stage 3s? Right, 0. And then how about stage 4? Right, we didn't have any of our stage 4s healed. They continued to have that. All right. So let's go through the rationale. Let me just scoot forward to the rationale here. All right. So the 2, we talked, I think we went through this. The 2 stage 2 pressure ulcers on the heels were present on admission and resolved. So the M0300B1 is coded as 2, and M300B1 is coded as 0 at discharge. And then M0900B, I'm jumping to the bottom because that makes sense to me. The stage 2 is coded as 2 because the 2 stage pressure ulcers that were present on the admission were healed by the discharge. So, and then M0300D1 is coded as 1 at the time of admission. And then we coded M0300D1 as 2 on discharge because now they had the one from admission plus they developed another stage 4. And then M0300D2 is coded as 1 on the discharge because only one of the stage 4 pressure ulcers were present upon admission. All right, so now let's take a moment, if you could, and we're going to spend just a couple of moments and then we're going to wrap up. Work with your groups again. Hopefully you've read through, so you're going to take out the training case study and you're going to take out your IRF-PI, your tool. And what I'd like you to do is work again with your small groups and determine how you would code M0300 and M0800 for Mrs. G's discharge assessment. So we're just doing the discharge assessment in this scenario. And we'll give you a couple of minutes. I don't know that it will take a full 10 minutes, but we'll give you a couple of minutes. So those doing the streaming video do the same thing. Take your case study, review it, talk to your table, talk to whoever's watching your the streaming video with you, and then go ahead and code the IRF-PI, and then we will talk through the results of that coding. We'll let you start now. Okay. Okay, how are we doing? Looks like most folks are done. A lot of great interaction. All right, hopefully those watching and streaming that you've also gotten through coding. All right, so we had our nice case study again. Remember to keep your case study and your IRFPI because you're going to need it tomorrow in a couple of activities. So let's find out about Mrs. G. So let's go through for M0300, current number of unhealed pressure ulcers at each stage. So how about stage 1? I hear one person. What do you think? Stage 1? Okay, how about stage 2? 0. Okay. Yep, discharge assessment. There you go. Good. M0300B2, stage 2 present upon admission. Skip. Okay. So we're skipping because there weren't any stage 2. Okay. Current number of unhealed pressure ulcers at each stage. M0300C1, stage 3. This is a discharge assessment. Okay. M0300C2, stage 3, present upon admission. 1. Okay. How about D1, stage 4? Okay. M0300D2, stage 4, present upon admission? Skip. Remember these skip patterns? I wouldn't worry too much about the skip. We put the skips in, but again, if it's computerized. Yes? Okay, let's see. Let's see. On discharge, they had a stage 3, because, right, it developed in July 11th. It progressed to a stage 3. July 11th, full, so the suspected deep tissue injury is full thickness, stage 3. Okay, so let's think about that. Why would we code it as present upon admission? What do we do when we have a suspected deep tissue or something that's covered by eschar, and the first time that we can code it or stage it, if it was there, right, it was either covered with slough or any of those unstageables, the first time that we can code it, if that slough and that unstageable was there upon admission, the first time we stage it, then we can code it as present upon admission. Does that explain it to you? Yeah? Okay, great. Sometimes we forget about that, but when you have that suspected deep tissue or again covered by slough, the first time that you can then stage it, because that was present, you didn't know what it was going to be, but you knew something was there. So when it finally declares itself, and now you know and you can stage it, now you can say it was present upon admission. Okay. All right. Current number of unhealed pressure ulcers at each stage on discharge. So M0300E1, unstageable, non-removable dressing. Okay. How about present upon non-removable dressing present upon admission? Oops. Yeah, skip. Sorry, that changed in font. F0300F1, stage unstageable to slough or due to slough or eschar. Okay. How about unstageable due to slough or eschar on present on admission? Skip. Good. Okay. Unstageable deep tissue injury. 0. Okay, because this is discharge. Unstageable deep tissue injury present upon admission. Skip. Okay. All right. So M0800, worsening in pressure ulcer status since admission. So this is newer worsening, okay? So stage 2. 0. How about stage 3? 0. Okay. Worsening and pressure ulcers are new since admission. Okay. 0. How about a stage 4? 0. So again, we go back to that whole thing. It was present upon admit. We had a suspected deep tissue, but the first time that we could stage it, now we staged it as a 3 and we considered it present upon admission. Okay. So in this sense, that stage 3 isn't worsened. Okay, that's really what this is, not new or worsened, because this is hard to wrap your head around. We had something there, we just didn't know what it was. And now we know that it's a stage 3. We know that, in fact, we can now make that present upon admission. And so here, it didn't get worse, and it's not new, because we had something there, it just declared itself. How about unstageable due to non-removable dressing? 0. Okay, we didn't have anything with non-removable dressing. How about unstageable due to slough or eschar? 0. And then how about unstageable deep tissue injury? 0. And again, it was that same kind of explanation. All right. So the lesson kind of in this case scenario we were trying to get to was that classic example of something coming in as either covered with slough or eschar, and or that deep tissue injury, suspected deep tissue injury. We're caring for them, we're doing everything. Then it finally just kind of what we call evolves, and it declares itself. We now have a clear understanding of what stage or how much damage is in that pressure ulcer. We now are able to stage it, we make it present upon admission, and we count everything from that point forward as if that came in as a stage 3 and we knew what it was. Okay, so let's look at summary for section M, and it documents the presence or appearance or change of pressure ulcers. So this gives us a sense about what we're dealing with around this important issue. And then we keep the overarching principles in mind when completing section M. Remember all those little caveats that I just talked about. M0800 is a new item coded on the discharge assessment, so you want to make sure that you go through these similar types of scenarios with your staff, because we want to make sure that we are getting accurate information on our assessments. And you don't want to, say something's worsening when in fact it wasn't, because you're not understanding the rules of the game. Some ideas for your action plan: you might want to revise your process to ensure tracking of all pressure ulcers and changes in pressure ulcer status in the patient record. I would want to make sure you ensure whoever is going to be coding the IRF-PI understands all of these little caveats. You want to make sure your clinical staff understands how to code and assess a pressure ulcer. Review your current way of capturing present on admission pressure ulcers and compare it to how these ulcers are captured in the new IRF-PI version 1.4. So again, making sure there's this new item, this M0800, so it's new, it's different, and we can't assume that staff understand how to code that. Be sure to add unstageable pressure ulcers to your tracking of new or worsened pressure ulcers if you don't already have that there. And then practice coding on a variety of scenarios with staff. Make your own up. Think about your own patients. Think about some of the stuff that's happening. Nothing's better than using examples from your own organization. Oh, Mr. X on Unit 1 came in, he was complex, and you go through this whole scenario. You probably could come up with tremendously more complex scenarios than what we've even talked about. And so write them all out, kind of talk about the journey, and then say, well, how would we code this? And then if you give this scenario after you've done training and you give this scenario to 7 staff members should come up with the exact same coding. If not, we now need to figure out why not. And then make sure that we re-educate and make sure that staff understand all the subtleties within the coding scenarios. Because there's a lot of subtleties here. And it's if this, then that. And those can be a little hard to wrap your brain around. So they get easier with practice. All right. So I'm opening this to questions for section M, and then right after I'm done, then Chris Gross from CMS and Ann Deutsch from RTI are going to come up and answer some of the questions that have already been submitted. So do we have any questions that I didn't cover in section M or any clarifications?
I wanted to ask on the example where the patient came in without any pressure ulcers, developed one, then was transferred back to acute care for 2 days, came back again, and you said it would still be not present on admission, which I assume is because it's an interrupted stay. What if it had been gone 4 days?
So then it would be a new readmission. It'd be a new admission coming back in.
And so at that point, you would say it was present on admission?
So they came.
Okay, they came into the IRF.
Ann's running up. She's been sitting quietly back there. We can let her. So again, this gets into the interrupted stay and whatnot.
Yeah. So with the IRF setting, if the patient is gone for the 4 days, more than 3 overnights, there's a whole new IRF pie, so it's a new stay. So on the first day, they didn't have a pressure ulcer, right? And it was while they were in acute care, but then they came back for a second stay. So on the second IRF pie for this patient, that pressure ulcer was present on admission, and it would be reported on the second IRF pie as present on admission.
So I guess the caveat that I think I got from your question is, so in that first IRF pie, they came in without a pressure ulcer. Mm-hmm. They were there for 5 days, 7 days. They developed a pressure ulcer, got sick for whatever reason, ended up in the acute care setting for 4 days, and now come back in. But what you're saying is a totally new admission, and that would be present upon admission, that pressure ulcer, that second IRF pie.
Correct. So it sounds, I'm sorry, the pressure ulcer occurred during the first day. They were discharged with it. So the first IRF pie, the first day, would have a new or worsened pressure ulcer by discharge.
Right, in M0800.
And then when the second IRF pie for the same patient, that pressure ulcer would be present on admission.
Okay.
It's its own kind of episode, is what
Yes,
you're trying
yes.
to say.
Each
Great.
stay, and for the quality measure, each stay counts. So it's not per patient, it's per stay.
Okay.
Does
Thank
that
you.
help?
Yes. I just
Great,
wanted to
thank
see if
you.
it was because of the
Hang
transfer
on.
rule.
Going to be coming back up. Any other questions for section M? I'm not letting her go because she's going to be coming back up here shortly anyway, so. No? I think you're all brain dead. I'm brain dead from all of these. If this, then that. Okay, thank you very much. So I'm going to turn this over to Ann and to Chris and Mark. I see a bunch of people running up. So thank you very much for tolerating me for the afternoon, and we will see you tomorrow. Thank you.